Thank you, and I appreciate the opportunity to be here this evening. My name is Harvey Chochinov. I'm a Distinguished Professor of Psychiatry at the University of Manitoba and a Senior Scientist at Cancer Care Manitoba Research Institute. In 2015, I chaired the federal government's external panel on options for a legislative response to Carter versus Canada. For over 35 years, I've studied psychosocial dimensions of palliative care, matters related to personhood and dignity in the healthcare setting. What I bring to the MAID conversation is my work on human suffering and research exploring why people might want to die. Based on that body of work, I cannot support the expansion of MAID for mental illness as the sole underlying medical condition. I have cared for patients struggling with chronic suicidality, patients whose suffering seemed irremediable, patients I worried might one day take their lives. I recall a woman with a mind-numbing depression who teetered precariously between life and death. One day, after years of countless drug trials, hospitalizations, ECT, and various psychosocial interventions, she arrived for her appointment 3 weeks into starting a new antidepressant with a grin on her face. "The door is purple," she declared. I told her the door had always been purple, to which she replied, "I know, but now I care." Before that moment, no one, not me, not her friends or family, not anyone on this committee, nor any MAID assessor could have predicted her recovery. The cornerstone of her care and of suicide prevention more broadly was the steadfast commitment to connectedness. The key ingredient of any successful psychological intervention is this therapeutic relationship. There is good evidence showing that the strongest predictor of suicidality, even amongst patients with advanced cancers, is the strength of connection with their healthcare providers. Our studies demonstrate that connectedness aligns with sense of dignity and that loss of dignity correlates with suicidality and desire for death. Our publications on dignity-conserving care and intensive caring are adding to the lexicon and scholarship of human suffering, and interventions such as dignity therapy, which is based on considerations of personhood and legacy, have been shown to target the psychological substrate of suicidality and MAID requests, including loss of dignity, autonomy, loss of control, feeling like a burden, and loss of meaning and purpose. Some witnesses have told this committee that there's a professional consensus that Canada is ready to introduce MAID for mental illness. This is simply wrong. What it really means is that there's a small, unrepresentative group of MAID providers prepared to step forward and say they stand ready. Well, the paper developed by the Canadian Psychiatric Association MAID Guidance Development Committee is meant to provide guidance. It does not, unfortunately, solve the riddle how to identify which patients have irremediable suffering, nor how to distinguish MAID from suicidality. Another form of readiness that you need to consider is that of Canadian psychiatrists, family physicians, psychologists, social workers, mental health counselors, pastoral care professionals. In other words, people who care for patients with chronic mental health challenges, which often include suicide, self-loathing, and marginalization. Adding MAID for mental illness into the mix will alter the therapeutic chemistry in every clinical encounter. It removes the vital guardrail from the therapeutic contract, which is to value patients' continued existence, to affirm that their lives matter, and to maintain steadfast connection. This, as much as anything we do with patients burdened with suicidality, is what keeps them alive. No wonder fewer than 30% of psychiatrists support MAID for mental illness and fewer for treatment-resistant depression or personality disorders. These patients live with chronic suicidality and are sustained by long-term care and caring. I know that some suggest that keeping the gate to MAID for mental illness closed will see some patients continue to suffer and even contemplate suicide, especially those unwilling or unable, I should say, to avail themselves of proper care. But there is no neutral position. If we wrongly tell patients that they will never get better and open the gate to ending their lives for them, many will walk through who would have recovered. So how many will line up at the gate? According to Dr. Scott Kim, extrapolating from Dutch data, we can expect 2,500 to 5,000 annual requests, about half of whom will receive MAID for serious mental illness. Limited prognostic accuracy means that at least half slipping past that gate would have gotten better, and likely more, considering that most patients with serious mental illness experience substantial recovery or long-term improvement over the course of their lifetime.
Okay, thank you
With
so much.
Artemis II mission currently top of mind, it feels apropos to say, Ottawa, we have a problem. And for all those reasons I've outlined, this mission made for mental illness should not proceed.
Thank you very much.